What kind of research are you guys up to?
Yeah, we're doing a few different things over here. So I have one quality improvement project that we're working on. On the endocrine side, we don't just do diabetes. So we have patients who will come in with hypoglycemia, not from insulin.
E-Shadowing live Monday night, December 13th, with not one, not two, but three amazing physicians here tonight to talk about their specialty, pediatric endocrinology. We have, I don't know if we call her the star of the show, but the most senior, because medicine, we love hierarchies, the most senior physician here, Dr. Vana Raman. How are you doing tonight?
Fine, thank you. How are you, Ryan?
I am great. I'm excited to have you. And I love that you brought some friends along. To your right, left on the screen, Dr. Hannah Jelly. And to your left, right on the screen, Dr. Michelle Meter. Welcome.
Thanks. Happy to be here.
And you two are both pediatric endocrinology fellows.
That's correct.
All right. So let's start with that, because new pre-meds going through this journey, or older pre-meds, or even some medical students still are like, oh, what the heck is a fellow? What does that even mean? What is that? Where are you on your journey?
That is a really good question. It is a long path. So we completed our 4 years of medical school and then went on to do our 3 years of our pediatric residency. We took our board exams and our board certified pediatricians at that point, but decided we wanted even more training. So we went on and decided to do endocrinology, which is in pediatrics, another 3 years of fellowship training.
I got you back.
Okay, I was going to say, hold on.
Froze for a second. So 3 years pediatrics, 3 years cut off at 3 years fellowship training.
Yep.
And then I was just saying that most pediatric subspecialties are, the fellowships are 3 years. So it's kind of like a typical timeline in terms of training if you decide to do that.
Very exciting. So after the 3 years fellowship, then are you finally like a real doctor? You're
Finally. Yeah.
Is it even through residency and fellowship? We're in the holiday season now, and it feels like medical students and even pre-meds hate this time of year because they go home and it's holiday dinners and all the relatives around. It's like, are you a doctor yet? Are you a doctor yet? Like, what do you answer as fellows? Like, no, I'm still in training. Like, what do you say?
I say that I'm a doctor.
Oh, wow. Been it for 5 years now.
Yeah. I know one of my family really understands either. Again, to some of these pre-med students. So
yeah.
I will say at this stage, though, explaining fellowship, you usually just say you're a pediatric endocrinologist. At this point, most people don't get what a fellowship is. So
Yeah, it's awesome. So the Vana, for you, let's talk about your journey a little bit. Since you're the senior attending here, we'll call you the attending. Why did you choose pediatric endocrinology?
Yeah, so I went into peds residency thinking I want to do hematology oncology, and I enjoyed the hematology part of it. The oncology was emotionally a little bit harder than I thought, and endocrinology, I've always enjoyed physiology. And to me, it was a lot of detective work, trying to put the pieces of puzzle together. And, truly one of the other big reasons is my mentor in residency was a pediatric endocrinologist who really inspired me. So that, and I did a diabetes scan, a great experience. And that sealed my decision to become a pediatric endocrinologist.
Yeah. So Vana, you just mentioned diabetes. Hannah, for someone who doesn't know what endocrinology is, what would you say that specialty is?
Yeah, no, that's a great question, because we do get asked that a lot. And I usually say it's a mix of diabetes and hormone problems. And sometimes I'll give examples: thyroid disease, thyroid hormone, growth hormone, stress hormones, trying to give an example to people. But I do think people think it is all diabetes, and really we're only about half diabetes.
Still a big chunk. And for you, Michelle, what interested you in the pediatric endocrinology world?
I think it was similar to kind of what Vana was saying. I really enjoy physiology, kind of thinking through problems
in that way. And so endocrine is just, really it's a lot of pathways and kind of thinking through and finding the missing piece, which is just kind of how my brain works. So I've always been attracted to that. I actually also came into residency thinking I was going to do gastroenterology, and quickly realized that was not for me. And so I was trying to just stay open and try to explore as much as I could, and then got a lot of exposure my intern and second year to endocrinology through our inpatient service and working with them in their clinic, and sealed the deal that way.
Nice.
Yeah.
And I think Hannah has a cool story. I'll let her share too. And Ryan, I will just preface by saying we're just lucky to have these two. They were residents at our Peds residence with us, and then chose to do endocrinology as fellowship. So we're just glad.
You didn't do a good enough job scaring them away.
Oh,
not yet.
No, my path was a little unique, a little different than most. So my dad is also a pediatric endocrinologist.
Ah.
So a pretty rare group. And then my brother has type 1 diabetes. So it is widespread in our family.
Yeah. So the question is, what came first, the chicken or the egg? Was your dad a pediatric endocrinologist and then had a son who was a type 1 diabetic?
It was that way. And it was no family history. So, just very coincidental.
Very interesting. Well, personal side of my story is my dad was a type 1 diabetic. And so that was a big part of my life growing up. Unfortunately, he passed when I was 17. But I remember clearly sitting in dialysis units with him and dealing with all that as a little kid and going through a failed kidney transplant at one point. I love the pediatric endocrinologist. I remember I was a camp kind of admin / counselor at a YMCA camp right after I graduated from college down at the University of Florida. And I remember he had to be like 5 or 6 maybe, type 1 diabetic, and he was just the cutest kid. And he would come in, and I just remember his like squeaky little voice that reminds me of like my 3-year-old son sitting upstairs. He goes, "I think my sugars are high." And we had his kit there and we test them like 400. Yep, sure enough, little Jimmy, your sugars are really high. The kids are phenomenal. Talk about that, dealing with kids and dealing with parents, because those are two different populations that you have to deal with. How do you manage that?
And Ryan, I'll just add one more thing, to your story. Sorry about your dad, but as you probably know, the face of diabetes has changed so much.
Oh yeah.
In the last decade, and much more so in the last few years. The technology, it is just incredible. Where we're even in the 15 years that I've been doing this, how much really things have changed in the last 3 or 4 years, and exponentially, how we have new technology that's coming and how it's really changed the quality of life and management and better control for, so I think that'd be a helpful perspective for your students to also know, how things are evolving. Yeah. And I'm sorry, coming back to your question
on kids.
Yeah. Do you wanna...
Yeah. I mean, you're definitely asking a trio of pediatricians. So we chose this for a reason. I think that there's many sides of it. It's definitely harder in the sense of there's differences at each different age, and you have to think of different pathophysiologies at each stage of life. A lot of times your patients can't talk to you and tell you what's going on. It can make for difficult exams, but they're so cute and they're so sweet, and they're always changing and growing. And that is one of the reasons I think most of us pick this specialty too, is we do get some of that continuity and get to know our cute little patients and have them grow up.
Vana, how long have you been out in practice?
Myself, 15 years. Yeah. Well, so counting fellowship, after fellowship, what did I do? 2009. So goodness, 12 years.
12 years. So since you've been out in practice, continuous glucose monitors and iPhones and that sort of kind of computer that we hold in our hand these days, and Apple Watches and everything, how have you seen that change your management and treatment of patients?
Night and day.
Night and day. Yes, that's exactly the word I was looking for. So let me tell you, for during fellowship and for many, many years afterwards, truly, Ryan, it was the same story for my patients. Test your blood sugars 4, 6, 8 times a day. I had some patients really testing them 15 times a day. They're poor fingers, but we just, there was no other way, right, to get all that data. So more you tested, the more data we had. And then when I was in training, the continuous glucose monitors first came out. They were uncomfortable. It was blinded, so the patient, it was not real time, so the patients did not have that information. And in the last few years, we have seen it evolve. So there was, that, I don't know if I'm allowed to say brand names, but one of the more common ones that we use in pediatrics, the Dexcom, it started with the G4 and the G5 that still needed 2 calibrations, meaning you test your blood sugar twice so that it stays accurate and put that number in. And then there's the G6. And honestly, I think that's been a game changer.
It sounds like a private jet line. Like I'm flying on the G6. Almost as expensive, but
it is, but now we have another version, option with the Freestyle Libre. And then Medtronic has its own continuous glucose monitor. So there's options.
Yeah.
So I've really seen it evolve and change over the last several years, but more so in the last couple of years. And once we have Dexcom that's continuously monitoring, we have the closed loop technology, right? So the Dexcom there's complex algorithms that is talking to your insulin pump and what's also commonly known as artificial pancreas or hybrid closed loops. So hybrid meaning you still have to put carbs in, and there's a lot of good things on the horizons. It's only getting better.
Yeah. I recommend everyone, if you're going to this field or not, there are companies out there where you can sign up. They're health companies. Sign up and you get a continuous glucose monitor. So I did that several months ago, and I had it on for 2 weeks, and it was fine. It wasn't uncomfortable. It didn't hurt. And it was just, the data was amazing. And luckily, knock on wood, my blood sugars were really good. So my pancreas is working well. Although it was very interesting that my sugars would spike during University of Florida football games. My cortisol would go, my insulin would spike. Oh man, I'm like, this is really bad for my health watching these games. Luckily, it's only once a week. So talk about, one of the things with this change is I've always heard, and I don't remember when I was a kid with my father, but I've heard from other people the anxiety around continuous glucose monitors, the anxiety around going to bed and having this huge window of not knowing what your sugars are. And it's like, well, am I going to wake up? Am I not? Like, what's going to happen? And my guess is that with CGM and now that it's kind of gone, and we have the ability to have alerts and alarms and stuff so that parents know. Talk about from a mental health standpoint how that's affected patients.
Yeah, sorry. That's a very good question, Ryan, and please feel free to weigh in. But, I think the best example I can give you is so there's our experience, and I'll let you weigh in, but there's also a study. So back in the day, parents, they'll tell you, 2 a.m. checks were very, very, very common. So, you're checking at 2 a.m. and it's hard to go back to sleep right away. And that was the norm for a very long time. And the tendency was to keep these kids, especially the younger they are, to go to bed at 250, or 300 so that they don't drop through the night. And I don't think any parent slept well. It's just hard, right? And so, or many parents didn't. Even with continuous glucose monitor, this is fascinating. There's a study called a Sense study. And so when they compared, even with continuous glucose monitor, the younger kids, they're what's called time in range. So the time where they're in optimal range so incidence of hypoglycemia was lower, but their time in range was still not as much as optimal as we wanted it to be, because again, the fear of hypoglycemia is still there in those parents, Whereas the older kids, even just continuous glucose monitor alone, the time of range dramatically, was improved. So, I think the younger the child, that fear is more so and often there. And I'll let our fellows talk about some real life experience.
Yeah, no, I think just in general, we, especially in our younger patients, we have families go home and they won't be on a sensor right when they go home, and I'm pretty sure we have parents just not sleep for 2 weeks until they get their kids on sensor. So it really does change their lives.
Yeah, and not only is reading it every 5 minutes, but it's also, it alerts you, and it has an algorithm built into it to where it doesn't just alert you when you're low. It can sense that the blood sugar is dropping rapidly enough where they're going to be low in the next 15, 20, 30 minutes. And so it can alert you and preemptively treat those lows. So I think it just gives parents and patients really good sense of mind.
Yeah. Vana, you mentioned some research, and I think you all are doing some great research. What kind of research are you guys up to?
Yeah, we're doing a few different things over here. So I have one quality improvement project that we're working on. On the endocrine side, we don't just do diabetes. So we have patients who will come in with hypoglycemia, not from insulin, from other causes, and we get a really fancy order set of labs called critical labs that are not very common to other specialties and often confuse people a lot when we ask them to order them. And they need to be when the patient is hypoglycemic, which is very hard. So you can't treat them before you get these labs. Wow. And so I am working on getting an order set into our iCentra, our EMR, that hopefully should make that way easier for people. And then my kind of other main project is working. We've shown that our technology, our insulin pumps and our continuous glucose monitors really improve diabetes care a lot. And what we also are seeing is, regardless of social status, financial status, anything like insurance status, our racial and ethnic minority patients are not utilizing our technology as much as our white population. So I have a grant-funded project that we're working to implement some education materials in other languages and focus with our team on really equally educating and encouraging technology.
You said that is despite kind of equating for social insurance, all that stuff, economic. Interesting.
Yeah, so that's the interesting thing. Yeah, we've looked at because, a lot of times you think more insurance coverage, those kind of things are going to be more of an issue. But there have already been studies that have shown that when they control for that, it still is quite a significant difference.
Wow, that's interesting.
Mm-hmm. Yeah.
And Michelle, what are you working on?
A couple different things. The first is that we, so typically, traditionally, DKA or diabetic ketoacidosis, which is the major complication we're trying to avoid with diabetes. But oftentimes, when kids are first diagnosed, or if they're not taking their insulin, they will present a DKA, and usually that is treated with an insulin drip and a lot of IV fluids. We've actually, really over the last 10 plus years at our institution, we've used, instead of an IV insulin drip, and those patients who come in who otherwise actually appear okay, appear well enough where they're able to tolerate PO intake, and their mental status is intact, that we've used kind of a basal bolus insulin regimen, like a subcutaneous insulin regimen, which is just not being done anywhere else. And so I'm just working on publishing that data, and hopefully that could really possibly change the way that we manage mild to moderate DKA and reduce costs and length of stay for those patients. So
yeah,
it's exciting. And then the second thing I'm working on is we also do treat transgender patients, and so we do help gender dysphoric youth to transition as part of our specialty. And so there is, once patients are started on gender affirming therapy, the ability to undergo fertility preservation is kind of greatly decreased for a variety of reasons. And so the recommendation is that you're supposed to talk to these patients about fertility preservation before they actually start undergoing these therapies, so they can make a well-informed decision. And it's really shown across, nationally, it's been replicated in multiple studies in adults and adolescents that those conversations aren't being had, or they're not being had effectively. And so people end up having regret down the line about not pursuing fertility preservation. And so my project is kind of just looking into that, and then kind of looking into ways to increase those rates and that make our patients feel like they made the most informed decision. So
yeah, That's awesome.
And they both submitted abstracts to the Peds Endocrine Society
like a proud mom.
today. Between the two of them, there's 3 abstracts. So I couldn't be more proud.
Working hard. That's awesome. And talk for a second, just because we're on the topic of research, and then I want to go back to DKA for a minute. There is always lots of confusion around whether or not you need to have a PhD to do research, or you can just be an MD or a DO and do research. Do any of you have PhDs? No. And you guys are crushing research.
Yeah, there's a ton of different facets of research. There's basic, bench, kind of what you would classically think of what research is, where you're sitting in a lab. But then there's also translational research, where you're using that some more basic research, kind of translating into clinical. And then there's true clinical research, which is really what we all do. Yeah. And I feel like that's what a lot of physicians do if they have a mix of both clinical and research time. Typically, most people's interests are more on the clinical research side of things. You absolutely do not need a PhD to do research.
Love it.
Yeah, no. And also, if research scares people, that should not scare them away from our specialty, because I know it was very intimidating to me coming into this, because I do not think of myself as a traditional bench researcher, but there's a lot of other ways to do research.
Got it. All right. So there's 176 people here with us right now. DKA, Michelle, you mentioned DKA, diabetic ketoacidosis. Let's talk about that for a second, because that is typically, I think, by the book, like an initial presentation of a type 1 diabetic coming in, going, okay, what's going on? And if I'm not mistaken, it's been a while since I've done this. There's usually some question of like, what's going on? There's a delay, and then a delay to start the insulin drip, et cetera. How can we help these 175 now? One person's like, I don't want to learn about DKA. How do we explain, number one, what DKA is, what that presentation looks like, why does it happen, and how can we, like my wife is a neurologist, right? Time is brain. How can we treat these kids faster, or sometimes adults?
Yeah, so diabetic ketoacidosis is typically going to be a presentation of type 1 diabetics. You can also see it in type 2. But they're essentially, these patients have a deficiency of insulin, right? So they've been attacking their pancreas to where the beta cells are getting killed off and they're unable to make insulin. So without insulin, your cells can't take up the glucose, right? So if you take in carbohydrates or sugars in your food, your body would typically, if you had a functioning pancreas, take up the glucose in your cells to use for energy. And without that insulin, you're unable to do that. So the body starts to look for other sources of energy. And in doing so, it'll break down like proteins, muscles, fats. And the byproducts of that breakdown are called ketones. And so ketones are acid. And so they're gonna raise the level of acid in the blood. So diabetic ketoacidosis. Yeah. So it's just from a deficiency of insulin. Because
so pause right there, because the people listening will go, well, that sounds like the keto diet. How is that healthy? Isn't that what you're trying to do with the keto diet?
Yeah, well, yeah.
There's not insulin deficiency, though, in those
correct.
Cases. The insulin is also required for acid-base regulation and electrolyte regulation. So, so there's, hopefully we will not have the keto people going into acidosis.
Okay, good. Okay.
Yeah, so totally, like Michelle said, the 3 components, so glucose greater than 200, ketosis, so elevated ketone bodies, and a bicarb level of less than 15 to 18, either one. So that would be acidosis.
Mm-hmm. And what do they look like on presentation? If I remember correctly, they're kind of out of it.
Yeah, so there's a wide range of presentation, kind of depending on how long they've been in DKA, how dehydrated they are. So if somebody's blood sugar has been sitting above 200 for days to weeks, your kidneys are going to try to get rid of that, right? And you're going to overwhelm your glucose transporters, and you're going to pee out all that glucose with all the water as well. So they're usually pretty dehydrated. That's the first thing. Usually they're going to be tachycardic and other vital signs or physical exam signs you would see, but just dehydration. Then they're going to be trying to get rid of that acid, right? So to breathe off acid, they're going to be breathing something called Kussmaul breath. So that's kind of the classic description of how a diabetic breathes. Kussmaul breathing, which are just kind of these really rapid, short, shallow breaths. To try to breathe off the acid level. And then the other, you can, if they are sick, and it's like if they're truly sick and they have been, there's been enough of dehydration and fluid shifts, you can see altered mental status. So that's kind of maybe what you're talking about with being kind of out of it. So confused, or incoherent, somnolent, to where they're not really responding to stimuli. That's due to kind of the fluid shifts and things that happen.
Which would be concerning for cerebral edema.
Yeah, I think really important things to know for even just anyone out there, an emergency medicine physician, a family medicine physician, internal med, kind of any of your general specialties, is to even think of some of the earlier signs, especially in pediatrics. It's really easy to miss. So people think, my kid is peeing too much. Well, they're just a kid. They are peeing too much. A kid who's already potty trained and starts wetting the bed should at least have their urine checked for glucose. I mean, that's just a really easy test to do. There's no reason to not test for that. We have plenty of kids who come in and they're breathing funny, and their lungs sound fine. They don't have asthma. They don't have any history. Might as well check a blood sugar in that case, because we've definitely had kids who've been treated for asthma and it turns out they're really sick and Kussmaul breathing. So I think those are some of those hidden signs in kids that people don't think about. But getting a urine sample is a very, very easy test. So I think when in doubt, just get one.
When in doubt, just get one.
Yeah.
What else should we talk about before we bring on some students to ask some questions?
I will just add to what both of them said, keeping a high index of suspicion. The polys, the polyuria, polydipsia, weight loss, like Hannah said, would be the classic signs. Sometimes we do see some kids, treated for gastroenteritis, and there's never been a lab sent, and sometimes they'll go home and come in really sick in a few days with severe diabetic ketoacidosis, which could have been prevented. So just keeping that in mind. Kid who suddenly starts going to the bathroom a lot or has lost weight, that's unexplained, or suddenly very thirsty, and or like Hannah mentioned, wetting the bed suddenly, or on a girl, vaginal candidiasis, in a prepubertal girl, oral thrush, blurry vision. Those are all just some of the signs to look for. What other things? Sorry. Yeah.
I was just going to say, a lot of what you're talking about, I think hopefully we get to a point of this kind of unrealized potential of EMRs, where the physician is putting in these diagnosis codes and typing specific keywords that they don't think are keywords, but the EMR is picking up with polydipsy, whatever. And the EMR is like, have you considered ordering a urine study? It's like, well, duh, like you should do that. We should have the standard of care built in with these, like, what are some potential, what's my differential? Even as the physician, if I'm not thinking about it, the computer knows. Like we have smart enough people out there to build this into EMRs. I don't know why it's there. And I can understand from a physician standpoint, it's like, well, you're taking away my autonomy and ability to think. I'm like, well, you can't think of everything all the time. So why not let the computer help you? What are your thoughts on that?
I think that's a great idea.
If that existed, I think you can get pigeonholed but also by a computer as well. So I think maybe it would be a nice adjunct to.
Yeah, an adjunct, right? That's all it is.
Yeah.
I may be a little old-fashioned here, Ryan. I'm a little mixed about that, okay? I think this is a different generation, and they're clearly very smart. I kind of agree with some of that thinking, but I think this could be a very good adjunct.
Mm-hmm.
What I think sometimes, so for example, we have power plans in the electronic medical record system, right? So our residents who work with us, I think our fellows know power plans, like in and out, they work then to prepare that. But sometimes when you talk about residents, right, if you're automatically, okay, there's a DK, let's do this power plan.
Which is a set of orders.
Which is a set of orders, right? Yeah. Sometimes I really do worry, are they missing out on that learning opportunity of actually thinking.
Oh, old school thinking. All right, Vana. So let's do a little test. Let's do a little test.
Oh my God.
How many phone numbers do you know by heart?
A lot.
You know a lot. How many, Michelle and Hannah, do you know?
Mom, Dad.
Yeah, it's like I don't even.
That's exactly what you're explaining, Vana. I think is a great analogy. People today don't know phone numbers. It's all in here, right? I only know my wife's cell phone number. That's the only phone number and my own, right, that I know off the top of my head, right? 911. I know that one. Everything else is here.
You're right.
And so I think in my mind, we as a society have to get away from everyone has to know everything, because we have technology all around us all the time. And yeah, sometimes it fails, but it almost never does. And so we need smarter people creating the EMRs to help us with this thinking so that we don't have to memorize everything, so that we can take care of our patients better, because they're very common presentations of patients, right? We have textbooks for a reason, because they're common things. And obviously we know about zebras, the ones that don't present normally. And then we work those into the algorithm in the future. But I think there's lots of potential to take care of patients better with some smarter EMRs. And I'm a huge tech nerd. I'll like the sign I have in the back mapped, like that's a software company that I started last year. So I'm a huge tech nerd and believe in the power of technology. So a random rabbit hole we went down. I'm going to bring on Sean. If you want to join, if any of you watching live want to come join and ask some questions of these three amazing physicians on with us now, you can do so. If any of you are software engineers on the side and want to develop a next level EMR, let me know. Like, I remember when I was an intern back in 2009, the iPhone had just come out 2 years before. I remember when I was on call, I would print out, like I had a stack of probably 50 pages with an iPhone like picture outline, and I would just sit there and doodle what different iPhone app ideas of like what.
Yeah, that's not me.
Anyway, John, come on and say hello. And unmute.
Oh, hi.
There we go. Hello.
Hello.
How are you?
Great.
How are you?
I'm great. I am not sure why I'm on.
You raised your hand.
I literally have no clue how that happened. I was just listening, and then I noticed my camera was on. So, hi guys, I'm so happy to be here, but I have nothing to say.
I'm sure you could come up with a great question.
I'm just kind of taking it all in. I had never considered endocrinology. I listened to all of the like presenting, and I think that EMR idea is really cool. Because just right now, like studying for the MCAT and everything like that, like I have no idea how I would look at somebody and be like, oh, this is like what's going on with you. And that sounds
repetition.
Amazing to have that tool to like be able to type in and be like, oh, okay, I should look out for this. So, no questions, but just commentary. It all sounds amazing.
Yeah, my goodness.
Okay. Sorry, you guys are kind of freezing for us intermittently.
Okay. I'm sorry. Well, Sean, thanks for coming on and not asking a question, but that's okay. Go back and hang out with the crew.
Okay, now we're back.
Now you're back. I see you now.
Yeah.
So again, there's no one else raising their hand. So if you want to come on and raise your hand, come do so. Come hang out with us. Michelle and Hannah were really excited about answering questions live. So come with some great questions. Let's go back to what a typical day looks like for you.
Yeah. So, I mean, one of the things that was most attractive about this subspecialty for me is that there's a mix of inpatient and outpatient. And so, we cover our patients in the hospital. And so if we happen to be, on that for the week. So if we happen to be on service for the week, it'll kind of look like coming in, pre-rounding on the patients in the computer, kind of checking in how things are going. Am I freezing? And then meeting up with our resident and medical student teams to go see the patients and round all together, come up with a plan for the day. And then we usually will kind of hang back and talk with the families even more about, their new diabetes diagnosis and kind of going through some of the teaching. And then typically there's somebody. Typically there's, we try to do some teaching in the afternoons and seeing patients and consults. So that's kind of what the inpatient's like. Vice versa, if we're in clinic, it's more of a clinic day. So typically it starts around 8 or 9 in the morning. And then we do, just because we're subspecialists, we do have longer appointment slots, which is nice. So we have more time, I think, to really get to know families and patients, but also kind of deal with more complex issues. So but we usually see like 6.5 day. Yeah. So 12 in a day. A
lot different than your like general pediatrician out there seeing 25 to 30 in a half day.
Yeah, that's a lot. Yeah. For the student / resident / physician in the future who loves to work with their hands and do procedures, is that a potential for endocrinology?
We don't do many procedures.
Yes. Not a lot. There are some pediatric endocrinologists who will do fine needle aspiration of thyroid nodules. It's just thyroid nodules and thyroid cancer. So relatively rare in children compared to adults. Typically, those are adult oncologists that will do those. But there are some that do that.
Maybe some do like maybe.
Yeah.
An implant
injection. That's pretty much it.
Okay.
Yeah. We're not big fans of procedure. Just for the 3 of us, that's why we're here.
All right.
Yeah.
All right.
We love what we do.
A little more of a cerebral field.
Yeah. All right. Some more questions. Pronounce your name for me. B?
Yes. Hi. Can you hear me?
Yeah.
Yes.
Okay. Yes. It's pronounced B. Hi.
Hi.
Yeah. So I think one question I had for you guys was, I don't know if you answered this earlier because I came in kind of late, but what attracted you to endocrinology specifically?
So I'll stop you because that was answered earlier.
Okay.
And you can watch the replay.
Okay.
All right.
Those are all the questions I had. So
that was a good question that we did cover earlier.
Okay.
So,
sorry.
Thank you. I'm sorry. I want to get to some new questions, and the replay is available tomorrow. Tressie.
Hello.
Hello.
Can you hear me?
Mm-hmm.
Okay, great. I'm so glad that I came today because I didn't know I get 3 lovely doctors to talk with. So I'm like very excited. I do have a couple of questions. I was really taken away by the type of research that you both are doing. If I remember the transgender thing, and then Dr. I think it was Hannah and Michelle.
Yes.
I don't know your last names, so I apologize. I want to learn more about how you get into those projects and more like the clinical research process, and if that starts only in fellowship or if that's something that's throughout residency, even in medical school, things like that. I'd be interested in knowing.
No, I think that we're very fortunate in that we really were able to choose our projects on our own based on what we were interested in, and we were really well supported by our division, which I think is a big advantage of where we're at. But yeah, I think these were definitely of interest to us. I have on my project with the racial and ethnic minority diabetes patients, I have a MD student on that project with me, and I have a pediatric or med-peds resident project with me as well. So we definitely include all groups.
Yeah, we personally both didn't do much research in undergrad or med school, or really even residency. I was a little bit always more so kind of, oh gosh. Okay.
Sorry, I'm putting my charger in, Brian.
That's okay.
All good.
In case you're wondering what I'm up to.
Yeah. So a lot of we didn't come into fellowship with a ton of research background, and we've been able to kind of come up with these projects based on like our interests, and just kind of sought out different people who have more experience doing what we don't really know much about, like research, but also kind of the specific sub specialty whatever we're doing research in. So we like working with people outside the division as well. So it's kind of about figuring out what's interested in, and then kind of not being afraid to reach out. Usually everyone is usually more than happy to help if you're interested in the same thing they are. Usually people are pretty excited and want to get you involved in things and are happy to mentor you on a more formal or more relaxed kind of basis. So yeah, I don't know if that answers your question.
Definitely.
I will add a little bit, from a program director standpoint, they had a research month in their first year, and typically for endocrinology, the second and third year are heavily research oriented, and the first year is primarily clinical. So they had 1 month for research, and in that month, they met with several people to see what projects are going on. If they wanted to join someone with their project or do something more independently with support, from our division. And, they chose their projects and have written it up, and it's an IRB. So, that's something they are passionate about, and came up with a question they want to see addressed, applied for a grant. So it's really been fascinating to see them evolve.
Just kind of learn as you go.
Yeah, it's all new, and you just learn how to do it.
That's great though. I think that you train so much in medicine, and then that there's this ability to learn more even in fellowship. That's not I don't know. It is clinical and medicine based, but it's not hard science. I think that's really cool. That's exciting. I have more questions, Dr. Gray, but I can go away now.
Yeah.
Okay. Bye.
Let's. I wasn't saying you could go away. Yeah. Let's yield the floor to Nadine next. Okay. Thanks, Jesse.
Thanks.
Hi, Nadine. Unmute yourself.
Maybe it's like my computer that doesn't like to use sound.
Yeah, it's still muted.
It always takes a second to find the button. There you go.
How long is
I know, right? It happens to all of us.
Okay, wow. Okay, sir, but I'm guessing you can hear me now?
Yes.
Okay, great. And so my question is, one of you lovely physicians, you first said that gastroenterology was not for you, and could you explain why you thought it wasn't for you?
I was going to ask that. That's a great question, Nadine.
Well, I first do.
Yeah, I feel like a really good piece of advice I got pretty early on in residency was, okay, what is the bread and butter of a specialty? And is that something that you could see yourself doing a lot of days? For us, it's diabetes, a lot of diabetes. There are other conditions that we see commonly too, but diabetes is a big one.
Some other conditions too that we see?
Sure. So I would say the other big ones would be, hypothyroidism is another one, congenital or acquired.
Short stature.
Oh yeah, short stature and puberty issues. Those are probably the big ones. For gastroenterology, it was constipation and chronic abdominal pain, and that just wasn't really my jam. So
and they do a lot of scopes.
And they do a lot of procedures, which I was not totally against, but I just didn't really.
What about IBS, like Crohn's disease, IBS,
IBD, and things like that? Yeah, that's all GI. There's a lot more of other things. So I just decided it wasn't for me. But it is, I have one of my very good friends is
yeah.
I love it, So it should, teach their own, but just not my job.
I think I'm way cooler.
Yeah.
I just
Thanks,
have
Nadine.
bias, just a little bit.
Yeah.
I just have one last question, and then I'll go away. But
Great.
I just wanted to ask, because you all mentioned about kids being cute and pediatric care, and I think it's fantastic when you're working with kids in a daycare because they're cute and they're healthy playing with their toys. But do you have a lot of issues working with kids and them being sick and have to deal with their parents who aren't being obedient, doing the medication or doing the treatments? Do you have major problems with that?
Every now it would be similar to adults not wanting to take their medication. I think we missed like the first half of that question, but I think we got it.
Yeah, kids are cute. Sometimes they don't take their
and then
medication.
Teenage years are hard. That's when compliance can be a bit of an issue. But the younger kids, it's easier because the parents are in charge.
And we do. It's not frequent that we have parents that just don't want to give the medication. That's very rare.
Yeah. Most parents love their kids.
Yeah, I mean it's not a common thing we run into.
Thanks, Nadine. Even with what we're going through with COVID, you haven't seen a switch in kind of the mentality of patients, or are your patients like, oh yeah, diabetes real and insulin is real, and so.
I don't feel like as much as a lot of other specialties, we don't deal with that nearly as much.
That's good. Yeah. That's good. Patrick.
Can you hear me?
Yes.
Hi. So I had kind of two very related questions. My first question is regarding I've followed international athletics for a while, and I remember there was a lot of controversy around a lot of intersex people competing in the Olympics, and I guess I'm wondering, how do you deal with people's natural conditions,
I lost him too.
Yeah.
We lost you, Patrick.
I would say.
Yeah, we lost him completely. All right.
Sorry. Sorry.
That's all right.
But yeah, I mean, I think just in where he was going with that, it can be really hard, especially with our true DSD patients, because we have a special disorders of sexual development or differentiation clinic. It's not uncommon in that clinic to see a patient who, was born phenotypically female, and then has some virilization at some point in their life, whether that be at puberty, and come to find out their, chromosomes, they're genotypically XY. And it's complicated. I don't know that we have there's not one right answer for that.
Yeah. Have you all listened to the Gonad series on Radiolab?
Actually, no.
So Radiolab, amazing podcast series, NPR series. They did, I think it was a 6 or 7 part series on gonads. It is phenomenal. I was listening to it so intent. I'm like, if they taught this way in medical school, I would have aced every board exam out there. It's amazing. So I highly recommend going and listening to that. And there was one episode on it. You talking about, Hannah, the kind of chromosomes of phenotypically female, but XY chromosomes. They were talking about newer research out there, and maybe it's not super new, about kind of our body's constant battle of flipping between XX and XY, of it's not as some people like to say, you're a man, you're a woman, chromosomes are everything. I'm like, well, the chromosomes are potentially constantly changing, and we have kind of like P53 for cancer. We have systems and processes in place to keep us a male or keep us a female. It's really, really interesting.
Yeah.
I know.
So go check it out and report back. Let me know. I want a 3-page book report or podcast report in this new age that we're in. Shane, we'll finish up with you.
Yeah.
Hi.
I did have one question about pediatrics. It's definitely one of an interest of mine, but what special considerations do you have to give with dealing with pediatric patients versus adult patients in endocrinology?
They're different at each age. I think that is something that you don't realize until you do your pediatric rotation, and you can't just give 5 milligrams of a dose. It is going to be per kilogram. And the pathophysiology is going to be completely different in a 2-week-old versus a 6-month-old versus a 5-year-old versus a 17-year-old. And you need to know all of them, but that makes it exciting.
Yeah, and I think, I think the assumption is that, kids are just little adults, but it's completely different, right? The physiology is totally different. definitely, yeah, just the medicine itself, which I think is what attracts a lot of people to pediatrics. It's different, different medicine, but also, you know, the considerations of they are not consenting individuals, so you have to, you know, kind of similarly, you know, piggybacking on what we were talking about with involving parents, and it's all about kind of family centered, you know, decision making, making sure, you know, parents feel empowered and the patient is getting the best care. So that's definitely a little bit different because there's multiple decision makers that are involved. It's different than just an adult patient.
Yeah, I will second, you know, what both of them said, and Patrick, I think one skill that's helpful to have, well, firstly, it's fun. I think that's probably a biased opinion, but we love pediatrics. It does take, you know, I think a certain personality. I think patience is a good virtue to have too, you know, and, you know, especially somebody who can't talk to you, can't explain, you know, their symptoms, the infants, the newborns, the really young children. And like Michelle said, you're treating not just the patient, but the whole family. And, you know, which I think is very rewarding. For us. And I mean, kids are just fun. You know, I tell med students, no matter how difficult your day is going, you see these cute kids, they're smiling, you can't help but smile back and really, you know, get to their level and have fun with them. So it's really,
I mean, you can have a really busy schedule with a lot of hard problems on it, but you walk in and you see a 4-year-old in their unicorn mask and rainbow shirt, and you're like, yeah, this is much better.
Nice. Thanks, Shane. Yep. So I want to end with a question that potentially may change the face of pediatric endocrinology and endocrinology in general, with stem cell therapy / artificial pancreas, maybe. It seems like we're on the precipice of that in the next maybe 5, 10, 15 years. What do you think about that?
I mean, I hope so.
Yes.
But I don't think we are quite there.
They've been saying that for 20 years.
There's two different things, right? There's the biologic cure, which would be more kind of stem cells and things. And there's the mechanical cure, so to speak, with the artificial pancreas, the pump system. I think that is, yes, we can achieve the mechanical cure. We're so close, like in the near future. Our next project we're excited about is a dual pump, so insulin pump that has both insulin and glucagon, because there's some dysfunction in type 1 diabetes with glucagon because of the exogenous insulin level. But anyway, a dual pump that's going to talk to the sensor. So I think the mechanical cure is really, I think, close. Where, you know, looking at a pump that you don't even have to enter the carb amount, which we're getting there. In terms of biologic cure, I think stem cell is very promising. There's some really good research. We're not quite there yet. So, you know, when I started fellowship, I know my attending kept, you know, was like, in the next 5 years, we'll have a cure. We're 12 years out and it's not there. So
I know there was a recent article that came out, and I think it was a bit misleading. I think we're all very excited, but in our field, we're pretty cautiously optimistic because I think they didn't really take a ton into account of how much immunosuppressives that you need to be on currently. And then it's still, even the longest possible benefit is a couple years. And so I think that there's promise. I just want to talk like a couple months ago about kind of more specifics regarding that. But I do think that'll be a little bit away.
A little more off. But we're working there. Yeah. But somebody's got to still do those things, right?
Yeah.
So we'll still have a job.
Yeah.
That's good.
Yeah.
That's good. Well, Dr. Jelly, Dr. Raman, Dr. Meter, thank you so much for spending your Monday evening with us and the students and sharing your passion for pediatric endocrinology. And hopefully we'll have some future peds endo people in the group applying to fellowship in the near future.
Thank you,
Awesome.
Ryan.
Thanks
for
for having
the
us.
pleasure. Thank you.
Yeah. Everyone have a wonderful night. We'll talk to you later. Bye.